Hello, I'm Dr. Miriam Laker-Oketta from the Infectious Diseases Institute in Kampala, Uganda. I'm presenting our work entitled Understanding the Circumstances Preceding Diagnosis Amongst Patients with Kaposi Sarcoma in East Africa. Sub-Saharan Africa bears the global brunt of annual KS incidents, and in addition, it bears the brunt of Kaposi sarcoma morbidity and mortality. It is documented that 25% to 50% of patients in Sub-Saharan Africa die within 1 year of Kaposi sarcoma diagnosis, and this is not accounting for those lost to follow-up and the undiagnosed. Approximately 90% of Kaposi sarcoma in Sub-Saharan Africa is diagnosed too late for any intervention to be of use. This Google search shows a typical presentation of Kaposi sarcoma in Africa. It is perplexing because Kaposi sarcoma has a characteristically cutaneous presentation, theoretically meaning that Kaposi sarcoma would be easy to detect in its earliest stages. A study done in Zimbabwe called the SIPO study found that educating only frontline providers in early detection of KS did not change the stage at which Kaposi sarcoma is diagnosed. This is not surprising if patients continue presenting with advanced lesions. It is therefore important to understand the factors contributing to late diagnosis of Kaposi sarcoma in Africa if useful interventions are to be crafted. To this end, our team set out to describe the health-seeking experiences of HIV-infected adults in Africa with KS, from initial cognizance of lesions to a formal diagnosis of Kaposi sarcoma. Participants on this study had to be at least 18 years old, newly diagnosed with Kaposi sarcoma, and receiving care or referred to one of 3 IDEA East African clinics. In Uganda, we used the Masaka Regional Referral Hospital in South Central Uganda, the Mbarara Regional Referral Hospital in Western Uganda, and the AMPATH network in Western Kenya. Participants were identified through a process called the rapid case ascertainment, which shall be detailed by another of my colleagues. We used the model of pathways to treatment, also referred to as the modified Anderson's model. Questions on the pathway to diagnosis included circumstances surrounding initial cognizance of lesions, the type of people consulted, and time points until a diagnosis was made. Of the 274 participants, 83% had advanced Kaposi sarcoma and were staged ACTG, tumor stage 1. 38% had at least 50 lesions, and participants had a median of 6 anatomical sites with Kaposi sarcoma. Regarding initial identification of lesions, participants reported 98% of the time being the first to notice lesions, and 71% of the lesions first noticed were in the lower extremities. Regarding help seeking, participants reported a median of 4.3 weeks to seeking help from anybody, and 91% said their first point of contact was a biomedical provider. Overall, participants reported visiting a median of 3 biomedical providers over repeated 3 visits before a diagnosis was made. These are some important timelines. Participants reported a median of 33 weeks from initial lesion cognizance to KS diagnosis. They reported a median of 6.4 weeks from first noticing lesions to contacting the healthcare system, and from first contacting the healthcare system to diagnosis, a median of 19 weeks. In conclusion, we observed multiple points of delay from initial noticing of lesions to a KS diagnosis, attributable both to patients and to their providers. Therefore, interventions to promote early detection of Kaposi sarcoma must target both the public and the healthcare providers. Patients should be taught to regularly examine their skin and mouth, and providers to ask about abnormalities. Patients should immediately show abnormalities to their providers, who must examine their skin and mouth at every visit. Participants or patients should be taught to ask their providers to perform a biopsy, and providers should biopsy any abnormal lesions or refer to a place where biopsy is possible. I want to acknowledge the different partners who joined us in this work. Thank you for listening.